welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Our next presenter is going to be Kaitlin Taylor, who's actually a fourth-year student at the University of Kentucky, and she will be doing a presentation today on the clinical outcomes of hypertonic saline versus mannitol in the treatment among children with traumatic brain injury.
And so to start, I kind of wanted to provide a little bit of background on TBI and like the mainstay treatments that we use for cerebral edema, and also some current recommendations in literature. So traumatic brain injury can kind of be divided or classified into two separate categories, and that would be primary and secondary injury. The primary injury is just like it sounds. It's the initial blunt force trauma. So, like in a motor vehicle collision, hitting your head on the dash or whatever that may be. The secondary injury is an injury that follows the primary injury within minutes, hours, or days later. Some of the causes of secondary injury can be things like hypotension, cerebral edema, and elevated intracranial pressure. And one of our main goals in patients with head injuries is to prevent these secondary injuries. And so these are kind of our two mainstay treatments for elevated intracranial pressure. The first of which being hypertonic saline. Works by drawing water from the brain. Typical dose for hypertonic saline using the 3% is going to be anywhere from 2 to 5 milliliters per kilogram over 10 to 20 minutes. It can also be given as a continuous infusion that's titrated to the goal ICP of less than 20, or you can also use the 23.4%, but the specific study mainly looked at the 3%. Some of the adverse reactions include various metabolic derangements like hypernatremia, hyperchloremia, metabolic acidosis, and extravasation. And it is also important to note that there is that potential for the central pontine myelinosis if the sodium is corrected too fast. For mannitol, it works via osmotic diuresis. Basically, it just reduces blood viscosity and therefore increases the cerebral blood flow, which leads to a reduction in cerebral blood volume. Typically, it's given at a dose of 0.25 to 1 gram per kilogram over 20 to 30 minutes. And again, you can have some of those metabolic derangements and also acute kidney injury, hypovolemia, and also rebound increased intracranial pressure as well. And mannitol also does require that filter tubing due to crystallization at room temp. And so that's also why we kind of keep it in a warmer to prevent that. So some of our current recommendations in literature, the first of which being the Neurocritical Care Society, they basically suggest hypertonic saline over mannitol for the initial management of cerebral edema in TBI, but they also make it important to note that neither should be used with the expectation that it's going to improve the patient's neurological outcomes. The American College of Surgeons say that evidence supports the use of hypertonic saline boluses or continuous infusion over the use of mannitol. And lastly, the ADAPT trial, which specifically looked at pediatric TBI, suggests that hypertonic saline is associated with a greater intracranial pressure reduction. But kind of like the common theme with all these is very weak recommendations and not a lot of evidence to base their recommendations on. And so that's why they use kind of like the vague language. And that brings me into the study, clinical outcomes of hypertonic saline versus mannitol treatment among children with traumatic brain injury. And so this was a prospective multi-center cohort study. It included patients that were less than 18 years of age with a moderate to severe TBI, so GCS of 13 or less, and the patients had to also be admitted to the PICU. Exclusion criteria would be a low GCS from other causes like hypotension or CNS infections that aren't necessarily related to its TBI, and also children that had cardiac arrest after trauma. And they kind of divided the groups into patients that received the hypertonic saline, patients that received mannitol, patients that received both, and patients that received neither. And so their primary outcomes of interest in the study were mortality and functional outcomes. And so they defined mortality as in-hospital mortality, and their functional outcomes were measured using the Pediatric Cerebral Performance Category, or PCPC, scale at hospital discharge, and the Glasgow Outcome Scale, the extended pediatric version, or the GOSE-PEDS score 3 months after their initial injury. And they defined poor functional outcome as moderate to severe disability, a vegetative state, or death. And the scores that kind of correlate with that, so the PCPC score of 3 to 6 would indicate poor functional outcomes, and the GOSE-PEDS score of 3 to 8 would also indicate poor functional outcomes. Some of the secondary outcomes that they looked at were things like sensory and motor function, communication, mental status, and also the patient's feeding and respiratory status. For this, they used the Functional Status Scale, or FSS, on hospital discharge, and a score of 1 indicated, these criteria were relatively normal for the patient, all the way up to a score of 5, which indicated very severe dysfunction. And so for the statistical analysis, they considered a p-value of less than 0.05 to be statistically significant. They also used multiple log binomial regression for mortality, and they also adjusted for age, sex, presence of child abuse, time between injury and arrival at the hospital, and also the lowest GCS score within the first 24 hours and presence of extradural hemorrhage. Authors also use multiple linear regression to study the association of the hyperosmolar agent with the PCPC score on discharge and the 3-month GOSE-PEDS scores. And it is important to note that their outcome analysis was first restricted to patients that either received 3% hypertonic saline or mannitol, but not both. And they subsequently presented comparison on clinical outcomes in all 4 groups. So again, patients that received hypertonic saline, patients that received mannitol, patients that received both, and patients that received neither. And so some of the important baseline characteristics that I kind of wanted to point out, while they included patients that were less than 18 years of age, as you can see, the max age was almost 12 years old. So they kind of didn't have any patients that were in the teenage years in the study. Most of the patients were male. As you could see, anywhere between 1/4 and 1/2 of patients required neurosurgical intervention. And also the time between injury and hospital arrival was at the median at the lowest would be 2.4 hours up to a median of 6 hours, which also takes into account that trying to prevent secondary injury as well. Most of the injuries occurred via road traffic injury, with falls making up the second largest portion. They also included child abuse and just an other category that just compromised all of the 1 and 2% mechanisms of injury. Some of the CT findings that they included would be subarachnoid hemorrhage, subdural hemorrhage, also cerebral edema, and a midline shift. And so for the results, they found out that patients that received the 3% hypertonic saline, about 31.5% had a poor functional outcome indicated by that PCPC score of 3 to 6. And about half had a poor functional outcome based on the GOSE-PEDS score. Around 20% of patients in the hypertonic saline group had seizures, where the median of duration of mechanical ventilation was around 5 days. And the duration of hospital stay was also around 16 days, with about 7 days of patients in the ICU. Patients in the 20% mannitol group, around 1/4 of them had a poor functional outcome defined with the PCPC score, and 63% had a poor functional outcome based on the 3-month GOSE-PEDS. And about 13% of those patients experienced seizures. The median duration of mechanical ventilation was around 4 days, with the median duration of hospital stay being 17 days. This result table includes all 4 groups. And one of the important things that I wanted to point out is that patients who received both agents had a significantly higher mortality rate in the study, whereas patients that received neither had the lowest mortality rate. So some of the strengths of this study were that it is a prospective multi-center cohort study across multiple countries and resource settings. So, taking into account quality of their hospital stay and the quality of treatment that they received. They used multiple analytic approaches to adjust for potential confounding. And they also had a reasonable sample size for this kind of study in pediatric patients. Some of the weaknesses were that it has an observational design, which leads to residual confounding and treatment selection bias. It was a heterogeneous population due to the inclusion of moderate and severe TBI, whereas, patients with a severe TBI can have significantly poorer outcomes afterwards, whereas moderate TBI, a lot of times those patients can almost completely recover. Their dosing, timing, and adjunct care variability across sites. So, there wasn't any kind of protocol set in stone. So you do have that intervariability among various sites. And it had a shorter follow-up time of 3 months. And we kind of know that TBI patients, especially with severe TBI, they can have to do, therapy, intensive therapy for several months up to several years after their initial injury. And so the authors concluded that the use of 3% hypertonic saline compared with the 20% mannitol was not associated with greater survival, reduced hospital length of stay, or better functional scores. They also suggested that further large multi-center randomized control trials are required to validate their findings. My conclusion from this study is that the agent of choice should be based on patient-specific factors if available. So, their current electrolytes, osmolality, their acid-base status, and volume status. Also taking into consideration the availability of either agent and the monitoring involved. I know some institutions, especially relatively small ones, may not have warmers for mannitol. Therefore, they should not deter from using hypertonic saline. And I will leave it open to any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.